Hello, my name is Dr. Padraig O'Sullivan, and I'm a neurologist at UT Southwestern. I'd like to talk in this video about the uh, path for workup for normal pressure hydrocephalus that you will be taking. So first, the reasons for proceeding with this testing. Diagnosing NPH is a matter of probability, not certainty. There's not a great test to say whether somebody does or does not have NPH. A condition can look like NPH and not be NPH, or a person may have NPH and it's very difficult to know if they do or not, frankly. So we collect and we weigh up evidence for and against, evidence such as symptoms and how they affect you and how your exam appears, and then we do some tests. Prognosis is not quite the same as diagnosis. Prognosis is trying to determine if a treatment is likely to help you. Obviously, that's related to the question of diagnosis. If a shunt is likely to help you, it fits with having NPH. However, sometimes there are cases in which NPH is not likely to be helped by a shunt. And so when we're doing our testing now, we're trying to determine, is this NPH and is it likely to be helped by getting a shunt? And we recommend a shunt if a diagnosis indicates a high probability that you have NPH. And if we think your outlook for the future is better if you have the shunt surgery than if you don't have the shunt surgery. So if you're watching this video, I am sending out questionnaires. They'll land in your inbox this afternoon, I think. And I hope you'll work through those. They'll come again in a year's time to follow up and compare change over time. Some patients will be referred for a brain MRI scan using the NPH protocol. Many of you will have had MRI done already, and if it answers all the questions we have and it's a good enough quality scan, we may not need to repeat it. Other patients, we will need to get another scan. I'm going to talk about a tool called One Step you can use to self-assess your own walking and track that over time. Then we're going to do some baseline gait and balance assessment in the clinic. We'll do a large volume lumbar puncture. I'll tell you about more in a few minutes. And then 2 days after having that lumbar puncture, you'll come back again to the clinic for follow-up gait and balance assessment and cognitive testing. And then 1 to 4 weeks after all that's been completed, we've compiled all the information, you'll be scheduled for a follow-up clinic visit to discuss your workup and then the decision, shunt versus no shunt. So I'll go through each of these steps. The questionnaires. This is one of the questionnaires. Asks you, are you able to get up and off the toilet, up and down the curbs, in and out of a car, things of that nature. The response options for each of these questions would be something like this: without any difficulty, with a little difficulty, and you give your best estimate for how things currently are or how they've been in the past week overall. Next, I'm going to touch on that brain scan. If a brain scan is ordered for you, we do need to be done here at UT Southwestern. Other places don't have the same protocol, and we don't usually get the images we need if you do it locally. The scan itself takes less than 30 minutes. It needs to be done before you have a lumbar puncture done, before you come for the large volume tap, because the removal of CSF in the tap will change the appearance of the things we're looking for on your MRI. We have slots set aside for the scanning, 8 o'clock and 8:30 a.m. every Tuesday mornings. They have carved out for us. If you're coming for a lumbar puncture, a large volume tap, they're usually on a Tuesday, mid-late morning. You could have the MRI done the same morning. If you're coming from a distance, you want to make it convenient in one trip. Or if you're local and you want to come do the MRI one day and do the large volume tap a different day, that's fine. You don't have to come on a Tuesday for the MRI, but we made it that way for convenience, for people who want to do the tap directly afterwards. This is just an image of the sort of things we want to look for. We want to be able to get a good look at your aqueduct in your midbrain, which can be obstructed in a minority of patients, and that would mean certain treatment options or testing would or would not be undertaken. We want to measure the volume of your ventricles, the width and depth of your sulci. That helps us in our diagnosis and prognosis information. If you have an MRI, it'll probably be scheduled at the Rogers MRI Center, which is at the Bill and Rita Clemens Advanced Medical Imaging Center. And I show that here on the map where that is in town. Your MRI could be scheduled at a different center, but if it's at the Rogers, which often it is, this is where you'll be coming. Next thing I'm going to talk about is an optional thing. If you wish to do this, you can track your own walking. You can download an app called Physical Therapy by One Step onto your smartphone. And this is the icon for it, the green square with the white one step. You can get it to your iPhone or to a Samsung phone. When you first install it, you're asked to give your name. I put my initial P-O, first name P, last name O, because for privacy reasons. Next, it'll ask you, do you want to allow messages to be sent to you from the company? And do you want your camera to be used and your microphone? And none of those are necessary for the purposes we're talking about here. It may ask you if you want to link to a clinician's office, and that you don't. We don't link with you, you don't link with us, so you don't need to do that. Anyway, once you've got it set up, I'll show you how to use it next. So I suggest you use it 2 to 7 times per week, random days, random times of the day, and measure your walking for 1 minute, and the app will save your scores. And then you can track over time whether your walking is getting better or getting worse, very variable, and whether treatments are helping. So with this one-step app, there's a home screen you'll see has 5 icons at the bottom. And one of them is called Measure. And if you tap that icon, then it'll come up with a menu, select an activity, and it'll be pictures of gait, walking, running, stairs, and you're going to pick walk. The next screen will ask you how long do you want to walk, and I suggest you pick 1 minute. And then next screen, it'll ask you where will the phone be placed? And your 2 options there, and I suggest you select your pocket. And it'll next pop up a screen saying, do you want us to track your location always? And I X that out. I don't want an app tracking my location always, just when I'm using it. Next thing, you'll get the screen with a green big button saying start countdown. And when you tap that button, it'll give you 10 seconds to get set up and ready to go. So you place the phone in your front pocket, ideally in a pair of trousers that doesn't swing around too much, because it wants to track your leg movements, your thigh, as it swings back and forth. Just one leg, but it'll know where the other is based on where your measured leg is going, essentially. You'll walk for you start walking, and at 1 minute's up, it'll sound out. It'll say to you, okay, time's up now. And you can look at your watch or whatever as well. But when you take it up, then it'll trap that information and put it in the app, and you can review it. It's best to go for a long, straight walk on a good, flat, open surface with few obstructions at a comfortable speed, not walking too much uphill or downhill or irregular surfaces or anything like that that would affect your walking. The only thing we want to affect your walking is your neurologic health. When you've collected a few of these, you can review your scores, as it were. Again, the home screen has 5 icons at the bottom, and if you select Journey, it'll come back to you with your score for the most recent time, and it gives you a score that they calculate between 0 and 100 based on many items about it'll say how many steps you went in that 1 minute, uh, well, how long you went, if you stopped early, how long you went. And so you can, from that, it'll come up with the speed, and it'll also give some things about your uh, steadiness between the two legs, and so on. And you can monitor your score over time. You can map out, this app already has in it, it's very easy to navigate around, I think, your score over the course of a few months, whether it's getting better or getting worse. Uh, and you can compare, for example, if you have a shunt surgery here, are you getting better or are you not? And it can periodically, and in the future, if things were going fairly well and then for some reason your gait deteriorated, this would be a quantitative indicator of that you could pick up on. Now, we don't get this data from the app, uh, but you have it on your phone and you can show it to us or tell us about it. And I think it's a little more reliable, let's say, than you or a family member saying, it seemed to me his walking was better before and now it's not quite so good. This would be a quantitative or a measured way of saying that. All right, next thing we're going to talk about is the inpatient, strike that. Next thing we're going to talk about is the clinic testing, and we're going to bring you back for sometime, hopefully in the next 1 or 2 or 3 or 4 weeks. We can get you into this. It's usually on a late Tuesday morning. You come to the UT Southwestern Cancer Care Outpatient Building, and this is a map showing where that is on campus. We do 2 things that morning. We do a baseline gait and balance assessment in the clinic, and then we do a lumbar puncture. The baseline gait and balance has to be done first. There's a physical therapist will watch you and measure you walking 10 meters, balancing on one leg, the other leg, walking in a narrow base, so on, turning 360 degrees, a number of other aspects like that, and the issues that are going into your walking. And they'll try record them down, measure, so on. Next thing would be a large volume lumbar puncture, and this involves you lying on your side, then a needle inserting local anesthetic in your skin, and then another needle going down when the skin is a bit numb, in between these bones of the vertebrae to take out some cerebrospinal fluid, or CSF. You'll still feel a needle going into your spine. It's the lidocaine is not going to take away all the sensation. We don't give you anesthetic for this or even oral medications. Most people, that can cause more trouble than benefits for this procedure. If the pain radiates to your leg, we'd like to know about it, so we'll reposition. Your spinal cord has come to an end higher up than where we put the needle, but there's some nerves passing through that area that can be tweaked and cause pain that goes into your leg. We take off 30 or 40 mils of CSF, which is about 2 or 3 tablespoons, and we send it off for analysis. But the main purpose we're doing it is to remove a volume of the fluid and have your brain reset with less fluid present, frankly. The procedure itself can take about 20 minutes. Having a lumbar puncture can cause side effects. Headache can happen, could be later the same day, could be the next day. Usually most people don't get a headache. If people do get a headache, it's usually pretty mild, but there have been cases where it's very unpleasant and goes on for day after day and even week after week, but that is not usual. It's as if there is a leak, that if the little hole we puncture leaks too much fluid, which would be comparable to what a shunt is intended to do, frankly. But if it's too much too soon, it may be experienced as a headache. Back pain can be experienced, and there's a low possibility of injury to the vessels or nerves or causing an infection. So after that lumbar puncture is done, we'll send you home. You get on with your day and the next day, and then 2 days later, that's usually on a Thursday. So we do the baseline baseline balance testing and the lumbar puncture on Tuesday. And then we bring you back 2 days later on Thursday, and you come back and you do gait and balance testing, usually the same place as we saw you on Tuesday. And then we do cognitive testing, similar to what we did in the initial NPH multidisciplinary evaluation. Where you get the cognitive tests, with the building on campus where you get the cognitive tests, depends on the availability of rooms and psychologists who are doing it. But similar testing to what you had done here in the clinic. And then you're off home again, and we'll compile up the results, and you'll get contacted for an appointment to discuss these, usually in the Aston Clinic, usually with the neurosurgeon, usually in person. Your case will be reviewed, and the decision on the table really is whether a shunt is likely to help you or to hurt you. And if the surgeon recommends the shunt, and if you agree, the neurosurgeon's nurse will schedule the surgery, usually a couple of months out, when the hospital and the insurance and your availability, surgeon's availability, all line up. If, on the other hand, a shunt is not planned, your care will be returned to your referring doctor. So this decision to recommend a shunt or not is a matter of balance. Some issues in favor of, some against, and ultimately we want to make the best recommendation we think for your individual case. Hope that's been helpful for you to understand what's going to be happening in the weeks ahead.